Welcome back, everyone. Today we are diving deep into what's really one of the most stressful clinical tightrope walks in modern cardiology. We're talking about finding that absolute sweet spot for antithrombotic therapy when a patient undergoes a complex percutaneous coronary intervention or PCI.
Mm-hmm.
The challenge is just immense, isn't it? You have to maximize protection against, a devastating heart attack or maybe stent failure,
Right.
while at the exact same time minimizing the risk of life-threatening hemorrhage.
It's a huge trade-off.
It really is. It feels almost existential sometimes. And navigating that decision space, well, that's what defines world-class care in interventional cardiology today.
Absolutely. And welcome to the funnel effect. The primary source for our deep dive today is really a crucial state-of-the-art review. It's titled Antithrombotic Therapy in Complex Percutaneous Coronary Intervention. It was published earlier this year in Eurointervention 2025. This is a really comprehensive analysis, expertly synthesized by Domenico Simoni Castiello, Angelo Oliva, and the esteemed working group of interventional cardiology of the Italian Society of Cardiology, among other key contributors.
Okay, great. So our mission today seems crystal clear. We're synthesizing the current evidence on both the rapid sort of peri-procedural strategies
Mm-hmm.
and also the long-term management of antithrombotic therapy, or ATT. Critically, we need to focus on how clinicians can actually tailor these powerful drug regimens, not just based on the patient's bleeding profile, but really on the precise objective complexity of the PCI procedure itself.
That's the key, isn't it? Understanding that complexity.
Right.
So over the past, 2 decades, PCI, using balloons and stents, it's really cemented its position as the most common way we do myocardial revascularization globally.
Yeah, it's standard practice.
It is. But as our techniques get better, we're taking on tougher and tougher cases. Our sources suggest that roughly 30%, maybe even a bit more, of all PCI procedures now involve some defined level of technical or anatomical complexity.
30%, wow.
Yeah. We're routinely dealing with patients who have really advanced, severe, often diffuse coronary artery disease. It's not the simple cases anymore, often.
And that complexity, it immediately changes the risk calculus for you, the patient, right? Which
Right.
elevates the role of antithrombotic therapy from just standard protocol to, like, a life-saving defense.
Exactly.
So when we talk about ATT in the context of PCI, what are the main goals? You mentioned 4 essential defensive goals.
That's right. The first goal is immediate. It's about minimizing the thrombus burden.
Mm-hmm.
This is absolutely critical, especially if someone's coming in with an acute coronary syndrome and ACS. There might already be a massive clot, and we want to prevent that dreaded no reflow phenomenon once we actually open the vessel.
Okay, stop the clot getting worse or blocking flow again makes sense. What's number 2?
Second, we have to mitigate the direct consequences of the procedure itself. I mean, let's be honest. When you go in and manipulate plaque, you're causing some mechanical damage. You might cause a dissection, or bits of plaque might travel downstream. That's distal embolization. The drugs need to prevent clotting that happens just because of that trauma.
Right, the intervention itself is a trigger. And the third goal?
The third is the one most people probably think of with stenting, preventing stent thrombosis. That's where the hardware of the stent itself suddenly clots off. That can be catastrophic.
Yeah, absolutely. And the fourth, you said it's often forgotten.
It is, but it's vitally important for long-term health. It's preventing ischemic events outside of the stented segments. We need to recognize and treat the patient's overall, often diffuse disease burden, not just the spot we fixed.
Okay, so 4 key goals. Now, we know complexity matters, but here's a challenge the sources highlight. There isn't really a universal standardized definition for complex PCI, is there? That makes comparing some older trials a bit tricky.
That's true. A single definition is still lacking. But, cardiologists have built a pretty strong consensus around several objective anatomical criteria. We know what generally puts someone in this high-risk group.
So what defines this group? What are those commonly accepted criteria?
Well, there's specific and measurable things. It often includes treating 3 or more separate lesions in the heart arteries, or implanting 3 or more stents during the procedure, or having a really massive total stent length, like 60 millimeters or more. That's a lot of metal.
60 millimeters, yeah, that sounds like a lot.
It is. Other flags are successfully tackling a chronic total occlusion, a CTO, which is a complete blockage that's been there a while, or treating a bifurcation lesion where an artery splits, using a more complex 2-stent technique. These all mark long, complicated, or highly intricate work.
Okay, let me jump in there. Why does something like total stent length over 60 millimeters automatically flag high risk? What's the mechanism?
It's both mechanical and biological. A longer segment of stenting means you've essentially put this massive foreign body, this scaffold of polymer and metal, into the artery. That huge scaffolding area increases the biological load for healing. It needs more time for the body to cover it smoothly, and it exposes a much greater surface area to potentially tricky blood flow patterns, different shear stresses. All that leads to a much higher chance of incomplete stent coverage by the body's own cells, and that can cause late thrombosis. Basically, the more metal, the higher the risk, period.
Got it. And what about those additional criteria you mentioned that also push a case into the complex category?
Yeah, these are often more about where you're working or how you're working, so treating the left main coronary artery, that's the big one, the main feed for the whole heart. That's always complex. Or doing PCI on a failing saphenous vein graft, an SVG bypass graft. Those are notorious for problems. Using specialized tools like atherectomy, that's when you have to physically grind away severe calcification before you can even place a stent.
Atherectomy sounds pretty intense.
It is. It signals really severe underlying disease and often means a longer procedure, more trauma to the vessel wall, and even just dealing with a single lesion that's very long, say 30 millimeters or more, can qualify as complex.
Okay. So this high degree of technical difficulty, as you noted, it creates this dual elevated risk dynamic. It's not just that they might clot, but it's when and why they might clot that differs.
Exactly. Complex PCI patients face a higher risk of early ischemic events. These are often due to mechanical factors. The longer procedure time, more vessel trauma, and really crucial problems like severe calcification that physically stops the stent from expanding properly. If that stent isn't perfectly opened and pressed against the artery wall, poor apposition, we call it's just a magnet for acute and subacute thrombosis, clots forming quickly.
Okay. So early risk from the procedure itself.
Right. And simultaneously, they face a higher risk of late ischemic events. This could be due to accelerated disease progression elsewhere, or sometimes outright stent failure months or years down the line.
And that, of course, loops us right back to the core conflict, the trade-off that makes this whole discussion so critical.
The bleeding constraint. It's the shadow hanging over every single decision here. The sources emphatically stress this point. Major bleeding complications, think a serious GI bleed or procedural complication needing massive transfusion, they might actually carry a prognostic impact, a risk of death or major problems that's similar to a thrombotic event like a heart attack.
Wow. So the bleeding can be just as bad as the clotting event you're trying to prevent.
Precisely. It means that trying too hard, being too aggressive to prevent clotting, can paradoxically lead to fatal hemorrhage. That clinical tightrope walk requires this incredibly precise calculation of the individual patient's risk profile, not just their risk of clotting, but equally their risk of bleeding.
Okay, let's focus now on the acute phase. The antithrombotic management used during the procedure itself. Primarily, we're talking about anticoagulant therapy here. And unfractionated heparin, UFH, seems to remain the foundation.
Yeah, UFH is still the default standard, and for a lot of good reasons. It's effective, it's inexpensive, it has a very rapid onset, and it's easily monitored using the activated clotting time, or ACT. And crucially, as you mentioned earlier, if something goes wrong, like unexpected bleeding, it can be rapidly reversed with protamine sulfate. That gives you a necessary safety valve.
Okay, standard reliable. But our sources noted that UFH management and ACT monitoring can get complicated, especially in these really complex, long procedures. How does the technical nature of a case like, say, a retrograde CTO PCI challenge standard ACT management?
Oh, it challenges it significantly. Firstly, these procedures can literally last for hours, which requires continuous, really meticulous heparin dosing and monitoring. You can't just give one dose and forget it. Secondly, in procedures that need a massive contrast load, the dye we use for imaging or involve big fluid shifts, patients can actually experience hemodilution. Their blood gets thinner temporarily. This can make the ACT reading potentially less reliable as a true indicator of the actual drug concentration right where you need it, at the site of the potential clot. So clinicians might feel compelled to aim for higher ACTs, often pushing above 350 seconds, just trying to be sure they have enough anticoagulation throughout the prolonged traumatic intervention.
But aiming for those higher ACTs, that carries its own danger, right?
Absolutely. While higher ACTs might seem protective against clots forming during the procedure, several studies, including the big TAO trial, have shown a pretty clear correlation between achieving and maintaining higher ACT levels, say, above 290 seconds even for radial access, and a definite increased risk of significant procedural bleeding. So the goal in complex PCI is often a higher ACT, but you have to accept that you're operating right on the precipice of increased hemorrhagic risk. It's a constant balancing act.
So what alternative might offer a potentially cleaner profile, maybe less bleeding risk than UFH?
Well, the main alternative anticoagulant discussed is bivalirudin. It's a direct thrombin inhibitor. It also has a rapid onset, but it tends to have a more stable, predictable antithrombotic effect because, unlike heparin, it doesn't rely on the patient's own antithrombin, the third levels.
Okay, more predictable. But wasn't there some controversy early on?
There was, yeah. Early in its history, big trials like the Horizons AMI study actually showed an increased risk of acute stent thrombosis and even heart attack compared to using heparin combined with GPIs, those potent antiplatelet drugs. That was a major setback for bivalirudin initially.
So how did interventionalists figure out how to overcome that early ischemic risk problem? Because that seems like a crucial insight for anyone listening.
It really came down to understanding the pharmacokinetics, basically, how the drug behaves in the body. Specifically, bivalirudin has a very short half-life, only about 25 minutes.
Much shorter than heparin.
Much shorter. Heparin's half-life is more like 60 to 90 minutes.
Yeah.
So what was happening was when the bivalirudin infusion was stopped immediately right after the procedure finished, the drug cleared so rapidly from the system. It potentially left this window of vulnerability, maybe an hour or two, before the oral antiplatelet drugs the patient takes could fully kick in and provide protection. The critical shift in practice was adopting what's called the prolonged infusion regimen.
Ah, so just extending the infusion for a few hours post-procedure.
Precisely. The evidence now really demonstrates that continuing a full therapeutic dose of bivalirudin infusion for 2 to 4 hours after the PCI procedure finishes effectively mitigates that early vulnerability window. And recent meta-analyses looking specifically at trials that use this prolonged infusion strategy have shown a clear reduction in cardiac mortality and major bleeding, importantly, without increasing the risk of reinfarction or stent thrombosis compared to heparin strategies.
Okay, so that makes bivalirudin a much more attractive option now, especially for complex procedures.
Yes, particularly in patients who are simultaneously receiving very potent oral antiplatelet drugs where maybe you want a slightly less intense anticoagulant backbone.
We should also probably note that intravenous enoxaparin, that's a low molecular weight heparin, is also mentioned as a viable alternative, apparently associated with reduced major bleeding compared to UFH in some large meta-analyses, particularly in the ACS setting.
Correct. That's another option in the toolbox. The key, really, is finding an agent that offers robust, reliable anticoagulation during the procedure without compounding the procedural bleeding risk, which we know is already inherently high in these complex cases.
Okay, let's switch gears now to the antiplatelet side of things, the P2Y12 inhibitors. Standard practice is aspirin plus a P2Y12 inhibitor paraprocedurally. For elective PCI and chronic coronary syndrome, or CCS, clopidogrel is typically the default P2Y12. The big question is, given the higher thrombotic risk in complex elective cases, why not just use a more potent inhibitor like ticagrelor or prasugrel routinely?
Yeah, this is a genuinely counterintuitive finding, and it really needs highlighting. You'd absolutely assume logically that the more potent drug would be better in a high-risk case.
That makes sense.
But the L8 trial had a sub-study looking specifically at elective complex PCI for stable CCS patients, and it failed to show any superiority for the potent P2Y12 inhibitors, ticagrelor or prasugrel, over standard clopidogrel in reducing those paraprocedural ischemic events.
Wow. So why do you think that happened? Why did the potent drugs fail to show a benefit in that specific elective complex setting?
Well, the source suggests, and it makes sense, that in elective, stable chronic disease, the main thrombotic risk isn't being driven so much by sort of massive acute platelet activation like you see in an ACS heart attack.
Yeah.
Instead, it's more driven by those mechanical issues we talked about earlier. Problems with poor stent expansion, long segments of metal creating turbulent flow, maybe some residual dissection flap, and those kinds of mechanical issues aren't necessarily solved by simply smashing the platelets harder with a more potent drug. In that specific stable context, the potent drugs just seem to add bleeding risk without providing an additional ischemic benefit.
Okay, that explanation really sets the stage perfectly for Cangrelor. This is the intravenous, ultra-rapid-acting, and crucially reversible P2Y12 antagonist. This sounds almost purpose-built for handling high-risk, maybe unplanned complexity during the procedure.
It really is like the cavalry for the cath lab in certain situations. Right. Cangrelor works almost immediately, within minutes, and it has an extremely short half-life. What that means practically is if the patient unexpectedly starts to bleed during the procedure, you can literally just stop the infusion and the antiplatelet effect clears very rapidly. That's a huge safety advantage.
And does it work? Does it reduce clots?
Yes. A pooled analysis confirms its benefit. It showed a significant reduction in early ischemic events, things like stent thrombosis or MI, within the first 48 hours, compared with just giving oral clopidogrel up front.
So when is Cangrelor actually used then? Is it routine?
No, not routine. It's a powerful option, gets a Class I level of evidence, a recommendation, and guidelines. Its benefit seems most pronounced in patients who have the highest number of complex high-risk features all stacked up, especially if they are P2Y12 inhibitor naive, meaning they haven't had their oral dose yet, and importantly, they aren't already considered at high bleeding risk. It basically provides instant maximal antiplatelet coverage right, while the most dangerous part, the procedure itself, is underway.
Okay. And finally, just a quick note on the old guard of potent antiplatelet therapy. The glycoprotein IBA inhibitors, or GPIs, where do they fit in now?
Yeah, they're largely relegated to the bench these days, you could say. Because of their significant association with increased major bleeding risk, GPIs are generally reserved purely as a bailout strategy. You'd only use them for refractory no reflow, where the vessel just won't open up properly, or if you actually observe significant thrombotic complications forming right there during the PCI itself. They're not used up front much anymore.
All right, let's transition now to the long game. Post-PCI, dual antiplatelet therapy, or DAPT, that combination of aspirin and a P2Y12 inhibitor is the standard for long-term secondary prevention. And it's a key observation from the source that having undergone complex PCI is actually an independent predictor for continuing DAPT beyond the standard 12 months. This affects a significant chunk of patients, maybe 20 to 40%.
That's right. That continuation, or prolonged DAPT, LDAPT as it's often called, has been tested extensively in clinical trials.
Okay, so let's look at the cornerstone evidence here. There was a major patient-level meta-analysis pooling data from 6 big randomized controlled trials covering nearly 9,500 patients. What did this massive data set reveal about LDAPT's impact on major adverse cardiovascular events, or MACE?
It provided really the foundational justification for tailoring the duration of DZRT based on procedural complexity. What it showed was that LDAPT defined in this context as continuing therapy for 12 months or even longer yielded a statistically significant reduction in MACE only in the group who had undergone complex PCI.
Only in the complex?
Only in the complex group.
Mm.
For the patients whose PCI was deemed non-complex, extending DBT didn't provide a significant MACE benefit. And crucially, the benefit in the complex group actually seemed to increase proportionally with the number of complexity features the patient had. So the more complex the procedure, the greater the benefit from longer DDPT.
Okay, so if you're complex, the benefit of long DDT for preventing clots or heart attacks seems clear. But, and here we go again, we immediately return to our narrative driver, the bleeding constraint.
Absolutely. The exact same analysis showed quite clearly that LDAPT was associated with a significantly higher risk of major bleeding. And this was across the board in all patients, whether their PCI was complex or non-complex.
So everyone bleeds more with longer DAPT, complex or not.
Correct. This universal increase in bleeding risk is really the single biggest impediment to just simply prescribing long DAPT for every complex PCI patient. You gain ischemic protection, but you pay a price in bleeding.
This inherent conflict then forced researchers to get much smarter about patient selection, didn't it? It led to looking not just at complexity, but also at the patient's own intrinsic high bleeding risk, or HBR. How did layering on that HBR assessment refine the strategy?
It created a much more powerful clinical roadmap. Basically, they ran another meta-analysis, this time looking at 8 RCTs, stratifying patients by both PCI complexity and HBR status. And what they found was this. For complex PCI patients without HBR features, so these are your high ischemic risk, but low bleeding risk individuals prolonging DAPT, typically out to 12 to 24 months, was associated with a decreased absolute risk of ischemic events, without significantly tipping the scales toward increased major bleeding liability. This is the ideal patient group for extended DAPT protection. High clot risk, low bleed risk.
That makes perfect sense. But what about the tougher scenario? The complex PCI patients who do have underlying HBR features, maybe they're elderly, have chronic kidney disease, or need chronic anticoagulation for another reason.
Right. In that high bleeding risk cohort, prolonging DAPT completely failed to provide an ischemic benefit that clearly outweighed the risks. In fact, it simply increased their risk of major hemorrhage. The clinical implication here is stark. If the patient has significant intrinsic bleeding risk factors, the theoretical benefit of prolonged DFPT in preventing clots is essentially nullified or even outweighed by the real-world harm of causing a major bleed.
So boiling this down, how do the European Society of Cardiology ESC guidelines summarize this based on the evidence? When is longer DIPT recommended?
Extended DFPT, meaning going beyond the standard 6 or 12 months, is recommended specifically for complex PCI patients when their thrombotic risk is clearly dominant, for example. Patients who presented initially with an acute coronary syndrome definitely fall into this category, provided their individual bleeding risk is carefully assessed and deemed to be low. For those high ischemic, low HBR patients, it gets a Class TI recommendation. That's something you should strongly consider.
Okay, so given that prolonged DAPT carries that universal bleeding liability, the next logical question cardiologists started asking was, can we maybe keep the really important P2Y12 protection, the drug that mainly guards the stent, while getting rid of the agent that causes most of the long-term bleeding problems, which is often aspirin?
Exactly.
This led to the whole concept of P2Y12 inhibitor monotherapy, specifically involving early aspirin withdrawal, right?
Precisely. The strategy really hinges on the idea or the observation that the P2Y12 inhibitor, whether it's clopidogrel or maybe ticagrelor, seems to be the primary protector against stent thrombosis, especially after the first few weeks or months. Meanwhile, aspirin, particularly when used long-term, is often the main contributor to those troublesome non-fatal bleeding events, especially gastrointestinal bleeds. So trials like Smart Choice and STOP-DAPT2 started investigating this. What happens if we stop the aspirin after just 1 to 3 months of DAPT and continue only with clopidogrel?
And what did those early clopidogrel monotherapy trials find, generally speaking?
Well, they largely supported the safety profile of doing this. Switching early to clopidogrel monotherapy did reduce major bleeding rates compared to continuing DET, and importantly, without statistically increasing the overall rate of ischemic events like MI or stent thrombosis. However, there's always a however. A pooled analysis of these trials did suggest maybe a small numerical increase in cardiovascular events among ACS patients who switched extremely early, like at 1 month. So it hinted that perhaps in the acute, highest risk setting, maybe you need a bit more caution with stopping aspirin too soon.
Okay, so promising, but maybe a slight note of caution for ACS. What about using a more potent P2Y12 drug like ticagrelor as the monotherapy backbone instead of clopidogrel? The evidence here, particularly from the big Twilight and Global Leaders trials, seems much more robust, doesn't it?
Yeah, the ticagrelor monotherapy data is arguably the most compelling support we have for this early aspirin withdrawal strategy, especially in higher risk patients. The Twilight trial, and specifically its Twilight Complex sub-study, which included over 2,300 complex PCI patients, it was pretty conclusive. It showed that switching to ticagrelor monotherapy after an initial 3 months of DAP led to a really significant, about a 44% reduction in major bleeding. And critically, this bleeding reduction came with similar ischemic outcomes compared to continuing DAP. This benefit held true irrespective of the specific procedural complexity features the patients had.
And Global Leaders back this up.
Global Leaders echoed the success. It used a slightly different design, but it specifically showed that a ticagrelor-based strategy, which involved dropping aspirin early, actually reduced the primary ischemic endpoint in complex ACS patients compared to standard long-term DAPT.
So it seems like P2Y12 monotherapy, especially with ticagrelor after a few months, is a really effective bleeding mitigation tool, even in complex cases. How do current guidelines integrate this strategy now?
Well, the current guidelines primarily recommend considering PTY12 inhibitor monotherapy after a short initial DBT course, mainly for patients, particularly those with ACS, who are assessed to be at high bleeding risk. It's viewed as a really high-value bleeding avoidance strategy in that HBR population. It allows clinicians to drastically cut down the hemorrhage risk without appearing to unduly increase the ischemic hazard, based on trials like Twilight.
Okay, very clear. Let's shift focus again slightly, now looking at the maintenance strategies after that initial year of therapy is complete. For decades, the traditional choice for long-term secondary prevention after PCI was just long-term low-dose aspirin, right?
That was the bedrock.
But the landscape seems to have changed dramatically with the results of the host exam trial. We really need to frame this as the paradigm shift that it truly was.
Oh, absolutely. This was revolutionary. For decades, as you said, aspirin was the untouchable backbone of secondary prevention post-PCI. Everyone got aspirin pretty much forever. The host exam trial directly challenged that dogma. It compared clopidogrel monotherapy versus aspirin monotherapy head-to-head, specifically for long-term secondary prevention in patients who had already completed their initial required DIAT period, which could have been anywhere from 6 to 12 months or more.
And what did host exam prove, not just overall, but specifically in the complex PCI subgroups?
It delivered what you could only describe as a knockout blow to the aspirin-only long-term maintenance strategy. Clopidogrel monotherapy was associated with significantly lower risks of both thrombotic events and bleeding events compared with aspirin monotherapy.
Both. Less clotting and less bleeding.
Both. Less clotting and less bleeding with clopidogrel compared to aspirin long-term. And this remarkable finding, the superiority on both fronts, was consistently observed across all the pre-specified complex PCI subgroups they looked at. It wasn't just a fluke in one group.
Wow. Less clotting and less bleeding with clopidogrel compared to aspirin for long-term maintenance. That is an enormous finding. It really challenges decades of medical dogma.
It absolutely is. And this overwhelming evidence has quite rightly resulted in a Class 1 level of evidence.
Yeah.
A recommendation in the latest ESC chronic coronary syndrome guidelines. Clopidogrel monotherapy is now explicitly endorsed as an equal or arguably superior alternative to aspirin for long-term secondary prevention after PCI. This is probably the single biggest shift in post-PCI pharmacology in the last decade.
Huge implications. Now, let's turn to almost the opposite philosophy, dual pathway inhibition, or DPI. This is where we deliberately add an anticoagulant, usually a very low dose of rivaroxaban, to an antiplatelet agent like aspirin. If we're so worried about bleeding, why on earth would we add another blood thinner?
Yeah, it seems counterintuitive at first glance. DPI is really our attempt to tackle the significant residual cardiovascular ischemic risk that we know persists in many patients, even when they're on optimal antiplatelet therapy. We know that clotting is basically a two-step dance. First, you have platelets sticking together, forming an initial plug. Then, the coagulation cascade kicks in, forming fibrin strands that solidify that plug into a strong, stable clot. DPT primarily targets that first step, the platelet sticking. DPI aims to hit both steps simultaneously. It inhibits platelet activity with aspirin, and it inhibits the coagulation cascade, specifically via factor zeta inhibition with the low-dose rivaroxaban. It's a double whammy.
Okay, attacking both pathways. The key evidence for this strategy comes from the COMPASS trial, right? What were the main takeaways there, particularly for patients who had complex PCI features in their history?
Right, COMPASS was the landmark trial. It tested adding this ultra-low dose of rivaroxaban, just 2.5 milligrams twice daily, to aspirin in patients with stable chronic coronary syndrome or peripheral artery disease. And it confirmed the powerful trade-off inherent in this dual attack.
Right.
DPI significantly reduced the rates of MCE major adverse cardiovascular events and, importantly, cardiovascular mortality. But predictably, it also significantly increased the risk of major bleeding compared to aspirin alone. Crucially, though, a pre-specified subgroup analysis confirmed that this net clinical benefit, the reduction in ischemic events outweighing the increase in bleeding for the primary outcome, was preserved in patients who had undergone complex, often multi-lesion PCI in the past.
So what's the clinical niche for DPI in this complex PCI world then? Who gets it?
It's considered mainly for extended long-term prevention, typically starting beyond the first 12 months after the PCI event. And it's reserved exclusively for patients who are deemed to be at high ischemic risk. And having complex PCI features absolutely qualifies someone as high ischemic risk, provided they are carefully assessed and found to be entirely without high bleeding risk factors. So if you have a patient with a really difficult complex PCI history and you're worried about their long-term clot risk and they have very low bleeding concerns, then DPI is probably the most potent long-term protective shield we currently have available.
Okay, let's drill down now into Section 5, focusing on 4 specific anatomical or clinical subsets that seem to demand unique antithrombotic considerations, starting with left main, or LM, disease. Treating the left main artery. Well, PCI there is inherently high stakes, isn't it? A thrombosis there can block flow to half the heart muscle or more.
Absolutely. The sheer procedural risk associated with LM PCI automatically makes it an ischemic risk enhancer. Because of the potential catastrophe that an LM stent thrombosis represents, extended antithrombotic therapy, whether that's longer DABT or maybe even DPI long-term, is generally felt to be justified. However, the data specifically on the optimal duration of that extended therapy is actually quite conflicting, which makes the clinician's job really tough in practice.
Right, you've got the controlled trial data, like that post-hoc analysis from the Excel trial, versus maybe real-world observational data. How do we reconcile those seemingly opposing views on extended DAPT specifically for left main patients?
It's genuinely challenging. The Excel post-hoc analysis, which looked at patients randomized in that trial, suggested that extending DAT beyond 1 year in LM patients did not show a clear benefit in reducing ischemic events, and maybe even hinted at potential harm because of increased bleeding. Yet, on the other hand, you have large dedicated observational registry studies focusing specifically on LM patients who were assessed as low HBr, and those studies suggested a significant reduction in ischemic events when DAPT was continued for more than 12 months.
So how does a clinician decide right there in the clinic? Do they trust the randomized trial trend, which maybe hinted at harm, or the observational data suggesting benefit in low-risk bleeders?
Well, they tend to lean on the clinical reality and the patient's overall risk profile. The ESC guidelines classify LMPCI itself as an ischemic risk condition, which allows for considering extended antithrombotic therapy, generally beyond 6 months for stable CCS patients and beyond 12 months if they presented with ACS. The general consensus seems to be that if the patient is clearly low HBr, the potentially devastating consequence of an LM stent failure pushes the scales towards maintaining protection for longer, while acknowledging the limitations and conflicting signals within the existing randomized data on duration for this specific subset.
Okay, a pragmatic approach based on risk. Next up, let's consider bifurcation PCI. This is where you're stenting a vessel right where it splits into two branches, a procedure known to carry a higher risk of stent failure.
Absolutely. The very mechanics involved, especially when using complex two-stent bifurcation techniques, inherently create this complicated metal interface right at a critical flow divider. This makes bifurcation stenting a clear ischemic risk criterion that justifies considering extended ATT. Now, while we don't have definitive large-scale RCTs focusing only on DDT duration in bifurcation patients, the registry data we do have is pretty compelling. Observational evidence from big registries like Kobe-Sissekin and data from the European Bifurcation Club strongly support the idea of prolonged DAPT, often going beyond 12 months, leading to a meaningful reduction in MACE and particularly stent thrombosis in these patients. The procedural complexity is just judged to be high enough that guidelines recommend considering extended ATT for both stable CCS and ACS bifurcation patients.
Got it. Moving on to chronic total occlusion, or CTO-PCI, what specific challenges in terms of drug therapy does dealing with this extensive calcification and complete chronic blockage present?
Right. CTOs present two major problems from an antithrombotic perspective. First, they're almost always heavily calcified. This makes it extremely difficult to achieve optimal stent expansion and perfect apposition against the vessel wall, which we know is a key driver of subsequent stent thrombosis. Second, the procedure itself to open a CTO is often very long, technically demanding, and can be quite traumatic to the vessel, further increasing procedural risks. Because CTOs are usually treated in stable CCS patients, the standard DABT agents are typically aspirin and clopidogrel.
So what's the recommended duration here, given those inherent mechanical challenges?
Well, European guidelines suggest considering prolonged DAPT, generally defined as going longer than 6 months. There are also some dedicated studies, like the work published by Sachdeva and colleagues, which found that continuing DAPT for more than 12 months in CTO patients was associated with a lower incidence of death, or MI, importantly, without significantly increasing bleeding risk. So opting for a longer duration seems like a reasonable choice for this mechanically challenging subset.
Okay. And finally, we absolutely must spend significant time on what might be the most challenging subgroup of all. Patients who require long-term oral anticoagulation, OAC, usually because they have atrial fibrillation, AF, while also undergoing complex PCI. These patients are, almost by definition, at high bleeding risk. This seems like the scenario where bleeding management totally dictates the strategy.
This is absolutely the definitive bleeding-centric scenario. The standard of care regimen here has evolved incredibly rapidly over the last few years, moving decisively away from using long-term triple antithrombotic therapy, that's TA, meaning DAPUP plus OAC, because TAT was associated with just devastatingly high rates of major hemorrhage.
So the current standard approach is explicitly designed to minimize the duration of exposure to TAT.
Okay, walk us through the current standard regimen for these AF patients undergoing PCI.
Right. The initial, very short-term strategy right after the PCI is indeed TAT. That consists of aspirin, a P2Y12 inhibitor, and here clopidogrel is usually preferred due to its lower bleeding risk profile compared to the more potent agents like ticagrelor or prasugrel, plus their necessary OAC agent, usually NOAC-DOAs. And this is the critical part. This TAT is maintained for an extremely brief period. We're typically talking about just 1 week, maybe even less in some protocols, perhaps only until hospital discharge. That strict 7-day limit roughly is there primarily to provide immediate maximal protection against catastrophic early stent thrombosis, while minimizing the total time the patient is exposed to that maximal bleeding risk combination.
Okay, so TAT for maybe a week max. What follows that ultra-brief TAT window?
An immediate transition down to dual antithrombotic therapy, or DD. DD in this context consists of just the OAC agent plus a single P2Y12 inhibitor. Again, usually clopidogrel is the preferred partner. Aspirin is dropped completely at this point. This DAT regimen typically continues for up to 6 or maybe 12 months, depending on the balance between the patient's thrombotic risk, including PCI complexity,
Yeah.
and their bleeding risk. After that, they usually continue on OAC monotherapy long-term for their AF.
What were the key findings from those pivotal trials, like Pioneer AF PCI and Redual PCI, that really cemented this bleeding-centric strategy, even when complex PCI was involved?
Yeah, these trials were absolutely crucial in changing practice. They consistently showed that switching to a DAT regimen, specifically OAC plus clopidogrel, or sometimes OAC plus low-dose rivaroxaban in Pioneer, significantly reduced the rates of major or clinically relevant bleeding compared to the older standard of continuing TAT for months. And importantly, this reduction in bleeding was achieved without showing an increase in the risk of stroke, which is the very event the OAC is primarily there to prevent or stent thrombosis. Even when these trial results were analyzed specifically in the subgroups of patients who had undergone complex PCI, the safety benefit of the DAT strategy held true. The bleeding risks associated with prolonged TAT simply outweighed any potential small ischemic or stroke benefit, reinforcing the message that minimizing bleeding has to be paramount in this OAC cohort, regardless of the PCI complexity.
Okay.
Safety first is the mantra here.
Wow. This has been an incredibly detailed discussion, really navigating the nuances of balancing today's established drug regimens. But let's look forward for a moment. Expert, you hinted earlier. Here's where it gets really interesting. What breakthroughs are currently coming through the pharmacological pipeline that might actually simplify this incredibly complex trade-off?
Yeah, the primary focus of future drug development in this space is really achieving better risk separation. What we desperately want are drugs that can effectively target the pathological clotting process, thrombosis, while ideally sparing or having much less impact on the normal clotting process that stops us bleeding hemostasis. We're seeing some interesting developments in novel delivery systems like subcutaneous, potentially self-administered P2Y12 inhibitors. There's one called selatogrel, currently in the SOS-AMMI trial. The idea there is for very rapid, maybe even pre-hospital, intervention in acute settings like a heart attack.
Okay, faster delivery. But what about that entirely new class of drugs you mentioned earlier, the factor Ingia inhibitors? Can you explain to the listener again how that specific mechanism might actually allow us to reduce clotting risk without necessarily increasing the patient's risk of bleeding to death? That sounds like the holy grail.
It really is the ultimate promise in this field. So factor warrior sits quite high up in the intrinsic pathway of the coagulation cascade. Crucially, current understanding suggests that factor warrior contributes significantly to amplifying thrombus formation, the pathological clot growth, but seems to play a much lesser role in initiating primary hemostasis, the necessary clotting that stops you from bleeding when you cut yourself shaving. So by specifically inhibiting factor warrior, as drugs like milvexian, which is currently in large phase 3 Librexia ACS trial, aim to do, the hope is that we can effectively decouple thrombosis from hemostasis. If this approach is successful, we could potentially target that residual thrombotic risk with an anticoagulant agent that carries a significantly lower intrinsic risk of causing major bleeding compared to our current strategies like DPI with low-dose rivaroxaban or even full anticoagulation. It really would be a game changer if it pans out.
Okay, decoupling thrombosis from hemostasis. Fascinating concept. So we've covered a massive amount of detail today. If you are a clinician, maybe listening to this, reviewing a complex patient, maybe they've got that massive stent length we talked about, a high-risk history, what are the fundamental takeaways from this deep dive? How do you synthesize all this?
I think it all boils down to personalized two-axis risk assessment. First, those key anatomical criteria for complexity that we discussed, multiple stents, long lesions, bifurcations, LMs, CTOs, they clearly define a group with persistent high ischemic risk. The definition of complex PCI is functional. It identifies high risk, even if it isn't perfectly standardized across all studies. Second, the careful, systematic assessment of the patient's individual bleeding risk, calculating an HBR score, is absolutely pivotal in deciding the long-term therapy.
Yeah.
You simply must know your patient's intrinsic bleed risk before you finalize the long-term drug regimen.
And how do those two factors, complexity driving ischemic risk and HBR driving bleeding risk, dictate the final strategy?
Well, if the patient clearly has HBR features, then P2Y12 inhibitor monotherapy, especially based on the Twilight data, using ticagrelor after 3 months, or maybe long-term clopidogrel based on host exam, emerges as the strongest strategy to minimize the risk of potentially devastating bleeding complications. Conversely, if the patient had a complex PCI but their bleeding concerns are assessed as low, then prolonged DAPT or perhaps the newer DPI strategy for even higher ischemic risk patients remain the primary options for providing extended aggressive protection against those feared late ischemic events.
Okay, and finally, we really need to address that real-world challenge the source material highlighted right at the end. We discussed how the criteria for PCI complexity are often unplanned. Maybe the need for a fourth stent or the discovery of severe, unmanageable calcification only becomes truly evident during the procedure itself.
Yeah, that is the ultimate tension point, isn't it? All these randomized controlled trials and the guideline recommendations that flow from them, they rely heavily on being able to do pre-planned risk stratification. We assign risk before the procedure, but if the patient's actual complexity status fundamentally changes or is only fully revealed once the procedure is already underway, how quickly and reliably can you pivot the pharmacological strategy in real time? This inevitable uncertainty, this gap between pre-procedural planning and intra-procedural reality, really challenges the perfect application of all this carefully gathered data. While pharmacology is definitely giving us better and maybe safer tools, we still have this knowledge gap, this action gap in real time in-procedure risk adjustment. Perhaps future technological solutions may be things like better intravascular imaging, giving us more upfront information, or perhaps rapid genetic assays for antiplatelet responsiveness done right there in the cath lab might eventually be needed to help close that gap.
A truly fascinating problem for future research and development. While we've certainly synthesized the current landscape, all the way from peri-procedural heparinization strategies right through to the revolutionary promise of factor V inhibitors for managing these high-risk complex PCI patients.
Thank you for watching The Funnel Effect.